So I'm Rachel Boothman. I work for the Huntington's Disease Association, which is an organisation that covers England and Wales. So we're the national charity that supports families living with Huntington's disease, and we also come to things like this. And my area is Hertfordshire, Bedfordshire and Buckinghamshire. So there are other advisors like me that cover the rest of the country. I'm actually an occupational therapist by training, so but obviously in this role I'm not clinical, but I'm here to sort of advise families and guide them and support them the best I can. So I'm just going to give you an introduction to HD, and we're just going to watch a video first of all. You probably heard Dr. Butterworth this morning say it is a genetic condition, which I think it's the only one out of all the conditions today that we definitely know it is a genetic condition. And it was only something that we discovered in we had our suspicions a long time before that, as you'll hear when I start talking, but we only had the test become available in the sort of 1990s. So I'll stop talking now and I'll let you watch the video. This is the experience of some families that are affected.
Dad didn't kind of sit down with me and we didn't have a discussion ever. We never spoke about the fact that I would be a risk. That just conversation never ever happened. But with friends, yeah, it was really difficult. I think I just said that it was a mix of motor neurone disease, Parkinson's and Alzheimer's. But that doesn't get across the little losses every day. The stumbles, every word forgotten, forgetting who you are, the aggression, like everything. So they didn't really understand, and they kind of thought, well, she's okay, she's not in hospital, so what's the problem, because she's okay at the minute. I guess I felt like they kind of brushed over it a bit, and I just felt really isolated. You're kind of mourning who your mum was, if you can remember, but you're mourning the mum she could have been, and then you're mourning the actual person when they actually die.
Okay, so that's obviously a lady whose mum has Huntington's disease, and obviously if a parent, we'll come on to this, but if a parent has Huntington's, and there's a 50-50 risk that their child will inherit the disease. So why is it so important to understand HD? It's a really complex condition, and those of you who support somebody regularly with HD will understand that the more we know about it, the better care we can provide. Everyone with HD is different, and so everyone will have need a slightly different approach. So it's kind of understanding the different nuances somebody may have in their condition and how you can actually support them with that. So when you have HD, it's very difficult to actually adapt your own thinking and to flex the way you see the world. You become quite fixed in your outlook. And so we need people like you in the room here to understand that and to be able to adapt to somebody. I think sometimes we feel that people with HD are kind of like, it's almost like they're doing it on purpose, or that it's a behavioural thing, they're just playing up, they're just, getting agitated, but quite often they can't control it, they can't help it. And it's knowing that and sort of having that in the back of your mind when you're supporting people. So it says there, yes, we do need to be flexible and we need to change our approach to people. So having a better understanding is a good place to start. So what is HD? So this chap that you can see here was a physician from the United States. He's called George Huntington, and he recognised that there were families that had the same symptoms. So within the same family, there were generations that were sort of showing similar presentation when he went to see them during sort of home visits. So it's a hereditary, this is a mouthful, a hereditary degenerative neuropsychiatric disorder. So it obviously progresses over time, it affects the brain, but it also affects how people think and how they feel. And it usually starts between the ages of 30 and 50. There is a juvenile form of the condition, but that is very rare, and that usually will be an onset before the age of 20. But usually people are between 30 and 50. And once they've started to have symptoms, they will usually survive from anywhere between 15 to 20 years. It's quite a long, drawn out sort of process. And you sometimes hear some people in the medical profession talk about stages of HD, and they generally go from 1 to 5. So there's approximately 1 in 10,000 people in the UK that actually carry the gene. So this gives you a good sort of indication of what's going on in the anatomy of somebody's brain with HD. So you've got the brain on the left there, which is a normal brain, and you can see that the grey area, which is the basal ganglia, is quite big, whereas on the other side, which is the brain of somebody with Huntington's, it's almost disappeared. The brain on the right is much more gappy as well, so you've kind of got lots of atrophy there. And I think sometimes it's useful to keep this diagram in mind. Again, going back to the behavioural side of things, if somebody is kicking off, you get lots of screaming sometimes with people with HD when they can't communicate what their needs are, and people get very frustrated. And I think bringing it back to this, it sort of helps you understand it's not within somebody's control. There's organic changes happening in their brain, and that's why they're behaving the way they are. So like I said earlier, it's only been since the 90s that we've known about this genetic test. So it's something that can be offered to anyone where there is a family history. So if a parent has the gene, then obviously the person can go for genetic counselling. That's usually what happens. If they decide they want to be tested, you have to be over the age of 18. And usually you'll be referred by your GP, and you'll go to the local genetic testing centre. You'll have up to 3 sessions with a genetic counsellor, and they will talk about, what does it mean? What would it mean to have a positive test? How, I guess, robust is somebody to accept that they might have a positive test? Sometimes people go through the genetic counselling process and decide they don't want to be tested. They may come back a few years later if they're thinking of having a family and decide then that they may have the test. Some people never have the test. They just don't want to know. They just want to live their life, and if it happens, it happens, and they just sort of take that risk, really. So it is a difficult decision. We often get people calling us where they've discovered there is HD in the family, sort of talking about what should I do, and we can't, there's no right or wrong. It's really about the people having the information that they need to make those informed choices. So we just advise them to go to their GP, get referred to a genetic testing centre, go through the counselling process if that's what they want to do, and then they can decide whether or not to go ahead with it. But it's obviously, it causes quite a lot of issues within families, lots of dynamic issues that come up that, sometimes we will be aware of a family member who has been tested, and they don't want their family to know, and so we have to be very careful in terms of confidentiality about what we can share with people and what we can't. So there is no cure for Huntington's disease at the moment. There is lots of global research going on worldwide, lots of social research studies, dozens of possible treatments. I think the fact that it is genetic and we know it's genetic, it kind of closes the options down a little bit and sort of brings us a little bit closer to what might be able to either slow it down or stop it in its tracks. The website address there, HD Buzz, is a fantastic resource. It's written by researchers, but it's done in a very plain English way so that everybody can understand, the different outcomes of research. So if you do have any patients, people that you are involved with, and they want to know about research, then I would definitely signpost them towards that website. So Enroll HD is the biggest study. That's got around 20,000 people taking part worldwide. And again, there's information on the website. And you can go on to that, be part of research to find out what other research trials there are. I think people generally within Milton Keynes will go to Oxford. Some people go to UHL. There's a specialist clinic at Queen Square in London where people can get involved in some research trials as well. So, what are the symptoms of HD? So you've got the physical symptoms, which are obviously visible symptoms, and we'll go through all of those. You have hidden symptoms. So the things that you can't see, it's a bit like Dr. Butterworth was saying earlier with the x-ray and the thigh and the broken bone. You know, you can't see often the thinking problems that happen, the cognitive problems that somebody has, and the mood changes as well. I think one of the things we really struggle with, and I know Anna struggles with this as well in her role as a coordinator, is where somebody with HD does have mental health symptoms, it's actually getting them into the right support services. We find that's a real struggle sometimes for people with HD. But you know, once they do get within those services and get the help they need, it makes such a huge difference. So we call it a triad of impairment, which represents these sort of three different aspects of how HD manifests itself. So like I said, no two people with HD are the same, although there is a sort of general pattern. So say, for example, if you have two people within the same family that have HD, if you've got a mum and a daughter or a father and a son, it doesn't mean to say that their disease is going to follow the same progression. They might get HD at a different time in their life, they might be different ages, they might have completely different symptoms. Somebody might be more physical in their presentation, whereas somebody else might be more psychiatric in their presentation, and other people can be a real combination of the two. So the severity and the order, there's no rhyme or reason to it really, it just varies, it depends on the person. Something that when somebody has a genetic test, they can find out it's called a CAG, it's the number of repeats of a particular the Huntington's gene has, and the higher, so generally up to sort of 40 CAGs is considered a sort of normal result, but if somebody has more than 40 repeats on their Huntington gene, then they will definitely go on to develop symptoms of the condition at some point in their life. So what are the physical challenges? So some of you might remember that Huntington's disease used to be called Huntington's chorea. Yeah. So does anybody know what chorea means? Dance. What language is it? Well done. So chorea is Greek word for dance. So often when you see people with Huntington's, they kind of have this like sort of writhing movement where they can't sort of stop moving, and that refers to chorea. But obviously HD is much more than just the chorea. It's, like I said, there's lots of other things going on. Some people will have changes to speech. We've got some cards at the back on the table that people with Huntington's can take away, which kind of explains, you know, I have Huntington's disease, because I think sometimes people think they're drunk or they're under the influence of drugs, when it's really just the speech changes that are happening for them. As we've heard earlier, changes to swallow, significant potential for weight loss, hunger, problems with sleep. We sometimes find people have a sort of reversed sleep cycle. So they'll be up all night and then sleeping all day. Some consultants will prescribe melatonin to try and help that. And it is helpful for some people, but not for others. And then problems with temperature control. We sometimes find people are, you know, in sort of heights of winter, they're in their shorts and t-shirts, or sort of not what you would expect in terms of what the weather is like. So thinking changes. So often people with HD will have slowed thinking. So you might ask somebody a question and it might take them quite some time to actually answer what it is you're asking them. And it can seem like forever, but if you just give them that time, they may eventually be able to answer. And it can be, so it can be very frustrating for the person themselves to actually, often people will try and jump in. People get awkward around silence sometimes, and they'll sort of try and answer for the person, which can be, even more frustrating. Recall. So sometimes people can't sort of access memories, and it makes thinking much harder for them to sort of try and remember things, getting started on things. So actually initiating tasks can be quite difficult for somebody. They can become quite apathetic and sort of just often sit and not really want to do much, but they can be quite happy sometimes doing that. But definitely initiation is something that we find people with HD can struggle with. Actually, once they are doing a task, it can be quite hard to keep them on track and keep them focused. So it can be something that would have been very simple for them to have done previously becomes much more challenging, and they can get sort of quite irritable and temperamental if things become overwhelming for them. So if you find there's an environment that's very stimulating, so say for example on a day like this when it's very hot, there might be a radio blaring, there might be a television on, or there might be people sort of talking and milling around, and it might just take one more bit of stimulation, and that kind of tips somebody over the edge with HD. Perseveration is something that we come across quite a lot with HD, where somebody gets very fixated on one particular thing. It could be smoking, it could be cups of tea. So somebody might say, I want a cup of tea, and you put a cup of tea down in front of them, and then 5 minutes later they want another cup of tea, and then another 5 minutes later, and they've got like 6 cups of tea in front of them, and it's just something in their head that they can't stop. It's like a sort of a fixed way of thinking. And then perspective, so inability to understand the wider picture and sort of what the impact on other people is. So within families, for example, some people really struggle to see how their behaviour may impact on their loved ones and other family members. Right, I want you to do a little exercise now. It's that post-lunch slump, isn't it? Have you all got a piece of paper and a pen handy? It's very easy, so I'm not going to get you to, don't worry, you don't have to move or anything. But if you've got a pen and paper handy, that'd be really helpful. This is an exercise from a book that I've got here, which is really useful. If you want to have a look at it, you can buy it. It is on our website, and the guy who wrote it, he's called Jimmy Pollard, and we've got webinars by this chap on our website. It's called Hurry Up and Wait. You all ready? Right, now this exercise is to sort of try and demonstrate what it feels like if you have slowed thinking. So first of all, what I'd like you to do is just write your name over and over again, maybe about 6 times. First name and surname. Just repeatedly write it. Just normal time, the way that you would normally. Okay. So I would imagine, we all know our names quite well, don't we? You've probably written that down pretty quickly. Okay. Right. So we're going to do another exercise now. Now, I know some people won't have 6 letters in their name, but however many letters you've got in your name, what I want you to do, and I want you to follow my lead on this, follow my instruction. So I want you to write, not yet, wait until I say, I want you to write the first letter of your name, but you've got to do it in 10 seconds. You've got to take 10 seconds to write the first letter of your name. You've got to do it really slowly. So when I say start, start, and when I say stop, stop. So start. Stop. Okay. So you're supposed to take the whole of that 10 seconds to write the letter. Okay, now do it for the second letter of your name. So start. Stop. Okay. Once more. Hopefully you've all got 3 letters in your name. Start. And stop. What does that feel like? Frustrating. Actually, what does it look like as well? Bigger. Okay. Yeah. Yeah. So imagine if your brain was doing that to you. Imagine if you could only do it at that pace when you're so used to doing it at your normal pace, and then suddenly everything slows down. You can't get your words out as quickly. You can't respond to somebody as quickly. You can't make your needs known as quickly. It's going to cause you a lot of stress, isn't it, and frustration. That's just a really small exercise to show you what it might feel like for somebody. Okay. So it's exhausting. It's annoying. You really need to think about it, don't you? And actually, it takes more effort. You can get distracted more easily. It can slow everything down and affect the quality, and it makes you feel like your automatic pilot is broken. So, if we're having a conversation, that kind of spontaneity that you normally have with an everyday conversation where you're having a bit of banter with somebody with HD gets a bit isolated from that because they can't do it the same way that they usually would have done. They can't laugh as quickly as they would have done. They can't respond. So it is extremely sort of frustrating for people, and it can contribute to the way people behave.
Can I just ask a very quick question because it's just on this part?
Yeah.
Once you've started to slow, do you have good days when your mind is better, or is it just like that?
I mean, it is generally a progressive condition. Things don't happen quickly. It's a very slow progressing condition, but it will sometimes depend on what's happening around you. So if you're really tired, you're probably going to be slower.
If there's days you can plateau.
Yeah, you might have better days depending on what the stimulation is around you and what's happening in your environment, how you're feeling within yourself. But generally, it will always be a sort of very slow decline. But there are things that we can do to help people, and I'll come on to that, sort of reducing stimulation and making sure people have got routine and reducing choices that we give people can all help with that. Yeah. So people obviously do get very frustrated. They can just think, well, what's the point? I'm just not going to talk because no one's going to listen to me. No one's going to let me answer. So I'm just not going to say anything. I'll just sit here and scream. And sometimes that's what people do because they don't have another way of communicating and getting their needs known. So social cognition. So I guess this is more about recognizing how our behavior affects somebody else. So for example, if somebody made a comment that was a bit embarrassing, or, a family member might take offence at that, but the person with HD wouldn't necessarily be aware. They kind of might not have that insight into what they were saying and how perhaps hurtful that might be to somebody, and they wouldn't understand how the cumulative effect that has can be really wearing on a family member or a carer. and how exhausting that might be. So it does definitely affect relationships, you know, family relationships, partnerships. We often hear of carers becoming incredibly, you know, that they care and they love their family member, but it becomes so exhausting and wearing when you're having to deal with perhaps somebody being abusive towards you or being aggressive towards you, but they don't necessarily realise that that's what they're doing. So this is Poppy. I'll let Poppy talk to you.
I'm a disease advisor, and I work for the charity the Huntington's Disease Association. My role is to, I say loosely support, but mainly advise anybody who is affected by this illness. My name is Alex Fisher. I'm an occupational therapist. An occupational therapist is a person who, if somebody else is struggling with what they do on a day-to-day basis, I work out ways to try and help them.
My name's Jen, I'm 32 and I'm from the Midlands. My mum had Huntington's disease. She died about 5 years ago, and she was ill for about 10 years before that, and me and my dad cared for her.
I'm Holly, I'm 25 and I have juvenile Huntington's disease.
My name's Billy and I'm Holly's dad. Yeah, I first heard about Huntington's disease when I was with my partner at the time, Holly's mum. It was a father that told me her mum had Huntington's disease and it's hereditary. So it came as a bit of a shock.
I was 6 when my mum was first diagnosed with Huntington's disease. I decided to take the test when I was 18. I found out that I had the gene just before my 19th birthday.
I just remember my friends saying, "Oh, what's wrong with your mum? You know, why?" Because she'd used to just have a big real temper and she'd just go just completely off the handle at nothing. It just seemed she overreacted to everything. Her speech started to slow down, and then she started to kind of stumble a little bit when she walked around.
Huntington's disease is known as a movement disorder, but actually Huntington's disease is far more complicated than that. It's actually a disease that affects cognition, behaviour, psychiatric behaviour, understanding of emotions.
The cognitive symptoms were a bit harder to spot because they were visual.
And sometimes the things are very, very subtle. So it might be that at work, perhaps you're a little bit more irritable than usual, or perhaps more anxious, or able to multitask. And all of those things start to affect every aspect of your daily living. And then, of course, there's your relationships, how you relate to others. Relationships can become really, really fractured. People might fall away because they don't understand. So perhaps you socially withdraw, or others withdraw from you.
It's difficult when you're trying to speak to someone and they can't process what you're saying at all. So our relationship faltered even further because we had nothing to hang on to as our mother and daughter relationship was completely gone. I think we needed a bit more space from each other to be able to have that, but I didn't have the space because I was obviously a live-in carer.
The symptoms have impacted greatly on Holly's life because she can't think straight, she forgets a lot of things, and also she's uneasy on her feet, and she has a lot of anxiety problems.
At 25 and I can barely do anything anymore. It's horrible having this illness. More speakable, and most of my friends go out clubbing or they go on holidays, things like that. But I can barely move anymore. And so I can't really enjoy any of those things.
Huntington's disease is a disease of families. I've seen marriages change relationships change. Social cognitive problems are about relationships and the connection between one another.
Mum's quality of life deteriorated really quickly. So she had no social life. She'd lost all her friends, and she'd lost friends over the past, 10 years because of her behaviour, falling out with people unnecessarily, over really petty things. Then she just ended up just sitting on the sofa all day, every day, and she didn't speak to anyone else. She didn't go out. I think she was probably suffering from depression. She just didn't know what was going on. She was very confused. I think the confusion also led to frustration, which led to aggression. Yeah, I felt under kind of immense pressure all the time.
It doesn't just affect the sufferer, it affects people close to them. It affects them mentally, because it makes them feel very uncomfortable. And also the mood swings, even though I know she's got the disease, when she starts to act really negative, I know I should tell myself that, it's just an illness. I sometimes just think she's purposely being nasty, but it's obviously not the case.
Okay, so I think that sort of demonstrates how it affects other family members as well. It's, we often, as sort of health and social care professionals, we're thinking about what can we do to make life easier, and it's thinking about that bigger picture, isn't it, about how it affects everybody around them as well. So some of the mood changes, so cognitive challenges can lead to changes in mood, apathy, anxiety, depression, and like we've said, anger and frustration, and people can struggle to control their emotions. They can become very frustrated over the sort of slightest thing. Something that to us we might just be able to let it go. They find it really hard to do that. And there's this sort of almost lack of ability to self-monitor. There's like a lack of inhibition for some people, where they just can't sort of stop themselves from saying particular things or behaving in a particular way, and that can sometimes lead to quite risky behaviour and misunderstanding from the members of the sort of community around them. And these are some of the reasons why mood might change. So we've talked about what's going on in the brain, but it's also looking at what those sort of unmet needs are in terms of, is the person hungry? Are they in pain? Is it because they're too hot? Are they bored? There's all these sort of basic things that we can think about first and sort of try to work through so that we can help them the best way that we can. It might be helping them to communicate more with like a simple low-tech aid if they're struggling to sort of tell us what their needs are. But by looking at some of these things, it might help us to sort of narrow down, why somebody is struggling with their mood. So what can we do to help? So it's thinking about communication, it's trying to keep things simple, just talking about one topic at a time. And if you're sort of asking somebody about what they want for breakfast, rather than actually asking them what they want for breakfast, it might just be, do you want toast, do you want cereal? Kind of reducing those choices so that you're not overwhelming them with too much thinking. Another example on there is thinking about the environment. So we were talking earlier about if somebody's in a very hot, sort of stuffy room with lots going on, lots of stimulation, it might be taking them somewhere quieter or just trying to reduce that stimulation to sort of reduce the feeling of overwhelm. Thinking about your reaction, in terms of if somebody is sort of talking about something repetitive, we always want to be professional, don't we, in our approach, and it's sort of trying to work out how we can best avoid confrontation if we can help that as much as possible. And there's a few more examples up there. I'm just aware of time. I won't. You can probably read them for yourself there. But thinking about those basic needs: are they hungry? Are they thirsty? Are they in pain? Is there anything that we can do to make their immediate situation easier and help their quality of life. Routine, I think, is really important as well. That can go the other way sometimes. If somebody has a routine and then there's a reason why you can't sustain it. So if, say, for example, somebody always goes out for a walk at 2 o'clock and there's a reason why that can't happen, it can sometimes go the other way and they can get incredibly frustrated that their routine isn't maintained. So you have to sort of think quite creatively sometimes. And this is just a bit of a kind of visual guide to help you think about problem solving. It's called the 5 A's, and again, it's in Jimmy's book here, Jimmy Pollard's book. So can you anticipate behaviour? Can you allow for it? Can you accommodate it? Can you adapt? And can you make arrangements to make things easier for the person? So if somebody is behaving in a way that's causing them distress and the people around them distress, it's worth just having a look at this to see if there's anything that you can do to help the situation. Just a kind of very visual guide. So this is an example in action. So this is a chap. So I'll just read it out there. My wife has driven me mad over the years by demanding cups of tea after the tea shop is shut and refusing to believe it's closing time. Another thing she does is refuse to budge until all the tea is finished, even though the place is closing. However, I've found a way to manage it. We go to one of our haunts late in the day and ask for a special pot of tea, and the staff are aware and they just give a half-full teapot, and that means that the tea will be finished. So this chap knows that his wife is always going to, it's like a toddler, isn't it? They don't want to leave the park, or they don't want to leave McDonald's until they've eaten all their chips or whatever, and you've kind of got to go. And it's knowing kind of how to manage that situation so that you're not going to be faced with the consequences of that sort of perseverative behaviour. So we do have a professionals area on our website, which is that's about the events and training. So if you go onto our website, there is a professionals tab that you can sign up to our professional mailing list, which tells you about all the other courses and sort of education opportunities there are. There's lots of webinars and recordings on our YouTube channel. I'm around, so if you ever needed any kind of extra information, we do other training. I think we've done some training with BJ Care actually called HD Champions, which is it's like an online learning module, and then people have 2 follow-up sessions where it's sort of talking about what they've learned in the module, and then we do some reflection exercises, and it's sort of looking at reflecting on how they care for people with HD and if there's anything that they can do differently, any changes they can make. We also have a professionals course, which is a 2.5-day course online that people can attend if they want more in-depth information about HD as well. We do have a service, like we've talked about the fact that it's a family condition, and often we will have younger people who are parents who have HD, who will have children, and we found that sometimes children, they can find it very frustrating or just not understanding what's going on with mum and dad. So we've actually got a youth engagement service, which is specifically for younger people, aged between 8 and 25. So if there is a family member who has children, we can ask one of our youth engagement workers to get involved. They've started running various activity camps and things, groups throughout the country. And it's just about giving those young people the opportunity for peer support and to help them to be, I guess, prepared for what life might throw at them later on. They have the potential to have inherited the condition themselves. And I think by having those networks early on, they feel they've got a community to support them. So I think it's really important. We do have a specialist HD advisor for juvenile Huntington's as well. And I've already mentioned the course there, the 3-day course. Yeah, that's just talking about the professional section on the website. We've got different sections for different types of professionals. So do take a look at that. We've got various guides as well. Obviously, we're on all the sort of social media channels as well. And yeah, thank you for attending, and I hope you've found it useful. There's lots that we can do to help people with Huntington's, although we don't have a cure or a treatment. There are obviously medications that can help with things like chorea, but it's not going to generally stop it. So, but there's lots that we can do by being flexible and responding to somebody's needs and anticipating problems that they might have. So thank you for listening.
Thank you, Rachel. Any questions?
Financial support like grants or
Yeah. So the question was about grants. So we do have it's called a welfare grant. So we have so within a calendar year, can you hear me? Within a calendar year, a professional can come to the organisation, and it's usually for anything that's not provided by statutory services. So it's up to £350 per year. And it can be for things like if somebody needs new flooring because they've got a wheelchair and a wheelchair won't run over their carpet, or we've got one at the moment where somebody needs air conditioning in their room because they're struggling to sleep at night and temperature control is an issue. So I think some people know who I'm talking about. Yeah. So yes, there is. Yeah.
so you just contact sometimes.
Yeah, there's guidance. If you contacted me in the first instance, or Anna, or you can go on our website. We do have a helpline as well. So if I'm not around, we have a helpline which is available 9 to 5, Monday to Friday, and they will get in touch with the local advisor if we're not available. But yeah.
Any cost implication for the 3 days course?
For
3-day course.
the 3-day course, there is a charge. I can't remember how much it is now. It's either £100 or £140, something like that. But it's really in depth. They have a geneticist comes and talks about the genetics. They have OT, physio, dietetics. It's a really in depth course, so it's well worth it. It's 2.5 days. They have case study discussions, and it's people all over the country attend. So yeah.
And a lot of your webinars have been recorded, haven't they?
They have, yeah. They're on a YouTube channel. Yeah. Kira did one. Bring on the cake.
It's very good.
Okay.
Anything else? Any more for any more?
We do have a support group locally at, is it Loughton? Is that how you say it?
Talbot at Loughton.
The Talbot at Loughton. So on a Sunday, first Sunday of every month, there is, it's like a lunch group where people with HD and their families can get together and just come and talk to each other and support each other. So the book is called Hurry Up and Wait, and it is available on our website. You can buy it on our website. Yeah.
It's a really easy read, and when you read it, you'll have so many light bulb moments when you go, oh God, yeah.
Okay.
Yeah.
Thank you.
Thank you.